Good evening, everybody. I have been asked to speak on challenges in pediatric pancreatic endotherapy. It's a very important topic because of its clinical implications, and therefore we need to discuss what are the actual challenges what we face when we do pediatric pancreatic endotherapy. And I want to thank at the outset the Indian Pancreas Club, Dr. Pramod Gar, Dr. Sudipto, Dr. Roop Jyoti for giving me a chance to be here. So ERCP first was used in adult in 1968, but it took almost 20 years to do the first pediatric ERCP. Since then, there has been an exponential increase in the number of pediatric pancreatic cases which are being done. And if you look at the graph, this graph basically shows that initially it was predominantly, ERCP was predominantly diagnostic. But over last 1.5 decades, now predominant pediatric ERCPs are therapeutic. The reason is, with such good cross-sectional imaging, now there is very little role of diagnostic ERCP in children. Now, this slide basically, in a nutshell, tells what we are going to discuss. Why we are discussing this? Experience with ERCP in children is very limited. The various reasons are, there is a relatively less incidence of pancreatic or biliary disorders in children which need ERCP. And it's an impression that this procedure is more difficult vis-a-vis this procedure in adults. And we are not very clear about what are the definite indications and what is the safety profile of doing ERCP in children. Simultaneously, there have been constraints in why we are not able to advance in this field because of lack of availability of adequately sized scopes and accessories and inadequate number of experts who can do this procedure safely. Now, there are multiple indications, but I have highlighted only the most common indications. It can be diagnostic, it can be therapeutic. Diagnostic, for example, idiopathic recurrent pancreatitis in children, we sometimes end up doing ERCP. For example, pancreas divisum, where we can do even minor papillary sphincterotomy. Pancreatic ductal abnormality on imaging, which is of not clear, what is clear, not there. Then acute biliary pancreatitis, especially in older children because of stones with cholangitis. Drainage of peripancreatic fluid collection, whether it's a pseudocyst or a wall of pancreatic necrosis, which are symptomatic. But two very typical indications are pancreatic ductal leak, which Dr. Anshu had discussed. It's a very important indication. It's a small subset, but the results are very gratifying if we are successful. Chronic pancreatitis is the major chunk with stones, with stricture or both. Now, if you look at the data from the INSPIRE cohort, over 1,100 patients, 1/4 of pancreatic ERCPs, pediatric ERCPs were of pancreatic indication. And out of pancreatic indications, more than 50% were because of chronic pancreatitis with pain. So it's basically the percentage of pancreatic indications are increasing. Now, if you look at the indication with the age in younger children who are less than 5 years, predominantly is the biliary indication. But in older children, pancreatic indications become more and more. Below biliary predominates, but pancreatic indication increase in older children. So this is how it correlates with increasing age of a child. Now, this is our data, which basically shows that out of 283 patients, 286 ERCPs, 270 were therapeutic. So predominantly therapeutic ERCP. In children who were less than 5 years, approximately 10% were for pancreatic indications. But if you look at children who are more than 5 years, 30 to 35% cases were of pancreatic cases. So basically, older children, more pancreatic endotherapy cases. That's what I would say. Now, there are certain very specific challenges in pediatric endotherapy. Number one, they have a unique anatomy and physiology. They have a smaller organ, which are narrower, which are softer. Tissue is delicate. And then the ductal anatomy, they are thinner ducts and they are more tortuous ducts. Second problem is availability of appropriate equipment. We don't have small scopes for small children. Accessory utilization is limited because the biopsy channel is of narrow caliber. It becomes very difficult to do more complex procedures. Positioning the scope in D2 is sometimes difficult because small children are more shorter D1. So it sometimes becomes difficult to focus the papilla. And then there has been inadequate innovation in this field, that we are not advancing, that we need newer accessories, better accessories, smaller scopes, so as to do the procedure safely and with a higher success rate. We have limited pediatric endoscopic expertise. There are very few people who are trained in pediatric endotherapy, and there is lack of standard guidelines. We are extrapolating the adult data to pediatric population. So this is a problem which may not be always valid. Now, when we think about a pediatric procedure, endotherapy procedure, we need to be very clear that what is the pre-procedure preparation. Now, in a child, we have to educate the child as well as the parents. It's very important. We need to give them psychological support because these parents are very anxious, child is small. So we need to reassure them that why are we doing the procedure and what are the benefits and risk involved. It's very important. We need to take the consent. If the child is older, we can take from the child, or if the child is younger, we need to take consent from the parents. Adequate dietary advice is very important, especially in smaller kids. Procedures in pediatric age group should be prioritized. They should be taken up early in the list because they are more prone to get dehydration and other problems associated with prolonged waiting. The smaller children are very prone to hypothermia. So we need to be clear that the temperature in the room is adequate, pre-procedure, during the procedure and post-procedure. And we need to, I am a adult gastroenterologist, I work in close collaboration with our pediatric colleagues. I get the whole clinical detail of the patient, what the disease is, what are the comorbidities, what we are planning to do, and post-procedure, how will we monitor the child. So what I mean to say, this has to be a close collaboration between the endoscopist and our pediatrician colleagues. Anesthesia and monitoring, there are certain points which we need to be clear. Now there is always the issue of deep sedation by endoscopy, which is known as monitored anesthesia versus general anesthesia. Ideally, all children, as per the guidelines, should have GA during the procedure. But the problem is this may not be practically possible. Every case can't be done under GA. Because there are certain risks which are involved when we do a monitored anesthesia. These children are more prone to hypoxia, more prone to hypotension. They have a narrow airway. Resuscitation sometimes becomes difficult in these children. So we need to be clear that whether we are going ahead with the deep sedation under endoscopic care vis-a-vis general anesthesia under the care of an anesthesia team. But now guidelines say that in children who are more than 10, 12 years, you can do the procedure under deep sedation. But my take on this is, it depends upon the age of the child, it depends upon what the weight is, comorbidities, which procedure we are planning, how complex is the procedure, what is the expected duration, how comfortable you are in your setup of giving deep sedation to a child, and what are the resources available. If anesthesia team is not available, then we are forced to do these cases under deep sedation. But we have to be very clear that it's very important that we looked at multiple factors before saying that this child is good for deep sedation vis-a-vis general anesthesia under anesthesia cover. Another important issue is lack of appropriate scopes and accessories. Now, if you look at the various scopes which have been in use, pediatric duodenoscope with a biopsy channel of 2 mm is the standard of care in children less than 10 kg. This is a scope which we commonly use. It's a very useful scope, but the problem is channel is only 2 mm and all accessories can't go. You can't use a triple lumen sphincterotome. You have to use a dual lumen sphincterotome. Accessories, most of the time we are able to manage with adult accessories, except triple lumen sphincterotome is not possible and we are not able to pass a guide wire which is beyond 0.025. So there are limitations of use of accessories in pediatric age group, but in most of the cases we are able to manage. But the problem only lies if the child is less than 10 kg, then we have limitation. Another point I want to show what is a diagnostic scope which Olympus has discontinued. This, fortunately, our pediatric gastroenterology team has got this scope. It's a very useful scope. In children who are between 10 to 15 kgs, this is a very useful scope. And where adult duodenoscope causes problem, this scope works. Now, why I wanted to bring this slide is lack of adequate expertise. This is a US data where 25% to 30% of patients, pediatric patients who needed ERCP for pancreatic indication, they could not get an ERCP done because of either non-availability of the person who does it or lack of adequate endoscopy setup. So this is the problem in the West, so we can imagine how big a problem will be in India. Coming to results, this is the retrospective data from AIG, almost 220 patients, out of which predominantly 170 were CP. They looked at pain relief with endotherapy, and approximately 2/3 of these patients had complete pain relief, which is very similar to what we get in adults. Now, this slide is a busy slide, but I want you to pay attention to three things. This is studies for pancreatic pediatric endotherapy. Majority of the studies did the procedure under general anesthesia. 2/3 indications were therapeutic, and adverse events were less than 10%. So very good results if done properly. ERCP in pancreas divism, it was discussed partially, I think, in the first talk. My take on pancreas divism in children is a little different. In adult, we say that it may not work because the incidence is very similar, response rate is very similar, but in pediatric age group, if we have pancreas divism which is symptomatic, this is the largest data which is retrospective, but it basically shows that approximately 60% patient had complete pain relief and 20% patient had partial pain relief. So it works. Now the issue arises is, once you have done an adequate pancreatic endotherapy in pancreas divisum, if patient does not respond, then the problem arises. Then we need to look at genetic study, whether there is a CFTR mutation or a SPING mutation. They have a thicker pancreatic juice, which is causing a problem, causing stent block, and the patient not responding. But as of now, symptomatic pancreas divisum, in majority of the cases, in a dilated duct with no well-established burnt out chronic pancreatitis, endotherapy does help in a significant number of patients. Childhood pancreatic trauma, Dr. Anshu has discussed this is our study from our center, which basically looked at role of ERCP. Number was small, around 12 patients, but we were able to either bridge the leak with stent or nasopancreatic thing, or we did a sphincterotomy, and 2/3 of the patient responded to the therapy. It's a small number, but it has got a role, especially in acute traumatic injury in children. Anomalous pancreatic epithelial union, uncommon, but approximately 80% of patients respond to endotherapy. Though this is a retrospective study, heterogeneous group, but significant number of patients respond. Adverse events, no big data, but is very similar to adult. But what I want to show is pancreatitis is seen in less than 8%, and only 0.6% were severe. So most of the patients will have, even if they have pancreatitis, it will be mild in intensity, and most of the children recover. These are the risk factors which I have mentioned. We need to be careful about these risk factors and then decide accordingly about pre-procedure prophylaxis. This is a COSARIC group study which looked at almost 430 ERCPs, and what we found was the incidence of pancreatitis was 10%. There was a positive association with pancreatic sphincterotomy and PD injection, and negative correlation with chronic pancreatitis and prophylactic stent placement. But these are all retrospective data. Another study, contrast. There was no advantage of putting a stent or giving rectosuppository to prevent post-ERCP prophylaxis in children. So contrast, jury is still out, we are not clear. But we personally give prophylaxis, and in older children we place a stent. Now coming to pharmacological prophylaxis, indomethacin we use it. The problem is in smaller kids, weight is a problem, we don't have small suppository. So there has been a study which had looked at IV ketorolac, 0.5 milligram per kg, and the incidence of PEP was much lower as compared to people who were not given prophylaxis. So this is an alternative if we can't give indomethacin or diclofenac, especially in children who are weighing 5 or 10 kgs. Fluid resuscitation, there is no data on in pancreatitis. This basically data I have extrapolated from, there's a recent article published 1 month back in Journal of Pediatrics. What they have looked at is role of fluid in acute pancreatitis. And what they have shown is that if we give fluid 1.5 to 2 times of maintenance, and how maintenance is calculated, this is by Holiday Segar, where for first 10 kg they give 4 ml per kg, and next they give 2 ml per kg, and beyond 60 they give 1 ml per kg. And with this, if you give 1.5 times to 2 times of this maintenance dose, their morbidity is much lower, their ICU duration is much lower, and reduced mortality. So I have tried to extrapolate this from acute pancreatitis, and it is not directly from post-ERCP pancreatitis. So this is how we manage it. We give a higher fluid, and our team also gives pediatric gastroenterology. They give 1.5 to 2 times the maintenance if patient gets post-ERCP pancreatitis. Coming to endoscopic ultrasound, because of lack of time, I will have only one slide. More than 15 kgs, we use the endoscope. Less than 15 kg, we need to use an ebuscope. Common indications are tissue sampling and picking up suspected CBD stone. Therapeutic, few indications, but what we do is peripancreatic fluid collection drainage, celiac plexus block, patient have refractory pain because of chronic pancreatitis, and occasionally US guided glue and coil placement. But as of now, 3/4 of indications are diagnostic for US in our setup. There are certain do's and don'ts in pediatric endotherapy. I'm sorry. I have 3 minutes to finish.
No, your time is over.
Yeah. So there are certain don'ts and do's. Appropriate indication, cross-sectional imaging must, multidisciplinary involvement is essential. We need to have appropriate scope and accessories, right environment, whether it's anesthesia cover, temperature, and so on. We should know when to stop. Stop if not successful. Bring the patient back another day, 90% chance you will be able to succeed. There should not be any learning of pediatric ERCP in pediatric age group. We should learn in adults and then get that knowledge and skill onto pediatric age group. We should avoid long procedures and we need to have patience. Children are more difficult to manage, but the results are so gratifying that we need to be more careful and patient. So take-home messages are the indications of pediatric ERCP expanding. We need to have advancement in our armamentarium, whether they're scopes or accessories. Results of therapy are very similar to adults. We need to have more training program in collaboration with adult gastroenterologists to train our pediatric colleagues to do the procedure better and better. And of course, studies are needed to get more data so as to become more wise in this field. Thank you.